how much things have changed with regard to end of life. What we're seeing is a growing collaboration with geriatrics, with palliative care, with spirituality, to take what many of us worked on and deeply believed in for decades about rights to choices at end of life, but affecting those have not gone so smoothly. We see huge differences across the country as we look at data in the Dartmouth Atlas and see profound differences in regional variability, in more than threefold stays in intensive care on a terminal illness in one part of the country compared to another. And where preference fits, where adequate relief of suffering fits, where respect for one's spirituality fit, where communication across disciplines fit, will be part of the charge for our next hour and a half. I am Susan Tolle. I'm the Cornelia Hayes Stevens Chair, and I direct the Center for Ethics in Healthcare at the Oregon Health Sciences University and will be this panel's moderator. I will also be our bouncer and will give each person a 5-minute warning. I'm harsher than Mark in that way, but feel there's a justice issue of respecting Dr. Salmasi, who follows behind us, and want to honor his time as well. To begin with, I will introduce the first speaker, Alexia Torke. She got her MD at Indiana University and did her fellowship here, an important theme of our panel, in 2007, and also had a Master's of Science in the Department of Health Studies here at the University of Chicago. She is an assistant professor of medicine in the Department of General Internal Medicine and Geriatrics at Indiana University School of Medicine. She's going to help us explore much more deeply issues around surrogate decision-making with a study of hospital DNR orders based on surrogate decisions. Please welcome with me Dr. Alex Torke.
All right, well, as that thing's coming down, I'll get started. Thank you for the opportunity to talk about some of the research I've been doing for the past years on surrogate decision-making. I'm glad that the previous panel paved the way a little bit in terms of changing your title, because I am going to talk about DNR orders, but I'm going to talk about surrogate decision-making as it occurs in the hospital for older adults a little bit more broadly. I want to start out by acknowledging my panel of mentors at Indiana University. They include Paul Helft, who's here today, as well as my research staff. But I also want to say a particular thank you to Mark for inviting me to speak today, and also to Caleb, Alexander, and John Lantos, who are really important mentors in the early phases of this work. So as many of you know, I've been kind of obsessed with the issue of surrogate decision-making for about the past 6 or 7 years. And I think what I find important about it is that I think that the process of making decisions for oneself about medical decisions is fundamentally different from the experience of making decisions for another. And I think that those differences in process have important implications for the healthcare system, for how people feel about healthcare, and I want to argue that they also have differences for the care that patients actually receive and for their outcomes. So as a consequence of this, I want to improve the process of decision-making in patient care, particularly for hospitalized older adults who are unable to make their own medical decisions. I think these differences are important, and I think we can intervene to affect them. Kind of as a first step in this endeavor is to really describe the landscape of decision-making in the hospital for older adults. And I think what I find is that although there's been a vast body of research about both decision-making and end-of-life care, there's actually been very little work that has isolated the decisions that people make for themselves compared to those made for others. And I think that this is kind of a particular lens to look at end-of-life decision-making that has been understudied. And so as I work to design these kinds of interventions, my first step is to really describe the landscape, and that's what I hope to do with this particular project. So the goal of my current project was to And I'll just say as an additional preface that when I came to Indiana University, one of the things I was immediately exposed to was the very extensive electronic medical record and computerized physician order entry system at the Regenstrief Institute, which provides a tremendous opportunity to look at the process and outcomes of patient care using electronic data. And I wondered if I could actually use some of this data to take a look. It's something that in the end is primarily an ethical and communication issue, which is how we make decisions for patients who can't decide for themselves. So the first project I undertook there was to examine the electronic medical record for evidence about the course of care, decision-making, and outcomes for hospitalized older adults who require surrogate decisions. So the particular objectives of this project were to examine the frequency that older hospitalized adults just face major decisions. Secondly, the frequency that surrogates must make decisions for the patients. And third, whether surrogate consent impacts the process of decision-making or the delivery of medical care to these patients. So again, our setting was an urban public hospital in the Midwest with a computerized physician order entry system and electronic medical record that are easily searchable by our research institute. And our subjects were all adults age 65 and older who were admitted to the medical and surgical services of this hospital over a 3-year period. So our methods were to do, first of all, an electronic chart review in which we obtained patient demographic and information, and then obtained information on the frequency of 3 categories of interventions that we kind of identified a priori as being important over the hospital course of older adults. Those included do not resuscitate orders, procedures and surgeries, and transfer to a nursing home at the end of the hospital stay. And because procedures and surgeries are such a heterogeneous group, we identified 2 procedures that are both common for older adults and for which the informed consent process is likely to take place in the hospital. And those are LPs and open reduction internal fixation of the hip and leg. That's in contrast to something like cath, where you might actually be making the decision to undergo the cath in the clinic and would only be admitted after the procedure. Now, the challenge is that the electronic medical record does not contain information as a general rule about who made the decision, and so we had to go do a text chart review to get that kind of data. So to do this, we randomly selected 75 charts for each of 4 decisions, and we determined the decision maker in a variety of ways. Procedures was pretty straightforward. We went to the consent form and determined who signed it. DNR orders are actually a required text field in the CPOE system, so when a physician goes to write a DNR order, they're actually required to state, I have discussed this decision with, and they must select patient, family, or both. Nursing home orders we found were actually far more complicated because the nursing home consent form actually goes with the patient to the nursing home and doesn't appear in the chart at all. So we had to look through chart notes to see the extent to which patients were involved, and so that variable was defined a little bit differently because of the data we had available. So what we found is that there were over 3,400 unique patients admitted over the study period with over 6,000 admissions. And as has been mentioned by other panelists, a lot of those admissions were repeat admissions. Keep in mind this is over a 3-year period, but it's a cohort of people who are frequently readmitted. Our first finding was that 56% of admissions involved at least one of the 3 major categories of interventions, suggesting that older adults in the hospital face major decisions quite commonly. When we broke it down by these different decisions, we found that of all patients, 15% were discharged to a nursing home, 43% underwent at least one surgery or procedure, and that's among all procedures that had ICD-9 codes and that we deemed serious enough to require a consent form, and 16% required a DNR order. When we looked at the 75 charts for each procedure that we examined by hand, we found that for nursing home placements, patients were uninvolved in 21% of the decisions. Again, we don't have clear data on who was the kind of formally the decision maker. For ORIF, surrogates gave consent 39% of the time. For LPs, it was 70%, and for DNR orders, it was 63% of the time. So you see here that surrogate decision-making is actually extremely common in the hospital setting, and in fact occurs a majority of the time for do not resuscitate orders and lumbar punctures. The next thing we did was to look at differences for each of these 4 groups between patients who made their own decisions versus cases where the surrogate had to make decisions. And actually, we found few differences with one exception, which was the category of do not resuscitate orders. And we found some interesting trends that led us to examine that whole group of patients in greater detail. And one of the trends I thought was most interesting is that there was a little bit of a signal that the surrogate decisions actually occurred later in the hospital course than the patient decisions. So we went on to investigate that in a little more detail. So we took all 957 DNR orders, and for ease of analysis, we only used the first admission during the study period for each patient. So we wound up with 726 unique patients. 57 either had our primary variable as missing or were ineligible. For example, we have prisoners in our system for whom consent issues are more complex. One partial code was in there, so we wound up with a final sample of 668 patients. So again, as before, we determined the decision maker for each DNR order for each of these patients. And in this case, we did a more fine-grained analysis, looking at decisions that were made by patients, by surrogates, or decisions that were shared. And again, with the hypothesis that DNR orders are written later in the hospital course when surrogates are involved. So here's a table of our basic findings. The cells that are in bold indicate that they're significantly different from the patient decisions. So the first thing we found is that when patients make their own DNR decisions, they're made an average of 3.2 days into the hospital stay, but when surrogates made decisions, it's an average of 6.6 days, and shared decisions are somewhere in between. So this does provide evidence that, in fact, when surrogates are involved in decision making, they occur later in the course of hospitalization. Patients who require surrogate decisions are slightly older, and they also are more likely to die, both in the hospital and at 30 days. In fact, if you're in the hospital and have a DNR order that is consented to by a surrogate, those patients have a 30-day mortality that exceeds 50%, so quite high. I want to show some survival curves just to kind of give you a visual sense of what we found. So in these graphs, decisions made by surrogates are in green, those that are shared are black, and those made by patients are in red. So as you can see, hospital day of the first no-code order occurs earlier for patients who fall off more quickly compared to both or surrogates. I think it's interesting to contrast this graph with the graph for mortality, in which the patients who require a surrogate decision actually die at a much more rapid rate throughout the hospitalization. And as you can see, situations where a shared or patient decision are made kind of tend to merge after a while. When you look at basically length of stay, you see that patients who require patients who make their own decisions tend to be discharged more quickly. And interestingly then, when you look at the number of days from the no-code order to death, or how soon the no-code decision is made in relation to when the patients die, decisions are made much more close to death for patients who require a surrogate decision. So there's a shorter interval in between the time that the decision is made and the time that the patient dies. So to summarize these findings, we find that 56% of admissions for patients 65 and older involve a major decision. Surrogates give informed consent over half the time for do not resuscitate order in LPs and commonly for other procedures. And for patients who have a DNR order sometime during their hospital stay, it takes longer to reach the DNR decision when a patient is involved, even though those patients are older and more likely to die. So our conclusion is that for some decisions, surrogate decision making should actually be considered the norm rather than the exception. And I think this gets back to our fundamental models of decision making, which usually start with the paradigm of the autonomous decisional patient. As you can see, that model is really somewhat flawed, and that that individuals are always subject to a variety of influences, some of which they're aware of, some of which may be entirely subconscious. But in fact, actually in the hospital setting, there are some situations where a majority of decisions are actually made by someone else. And we should view surrogate decision-making rather as kind of an anomaly that's off to the side, but really as a central part of decision-making within the hospital setting. I think that this numbers-based data can kind of lay the landscape, but it really only kind of asks more questions than it answers about why decision-making takes longer. And I think some of the other work that I've done and others in this room, I think point to some of those possible explanations. And they include particularly the complexity of surrogate clinician communication. For example, patients are there in their hospital bed throughout the entire hospital stay. They're there, you can find them. Family members may be more complicated to locate. Family members often complain that it's extremely hard to find the medical team when they want to. And so simply the logistics of conversation are actually much more difficult. And then it's more ethically complex and entirely different to be making a decision for someone else than to be making it for oneself. And it's true, and it has all kinds of manifestations, and that we're much more likely to take at face value the decisions people make for themselves compared to others. And I think surrogates often feel a tremendous emotional burden when making a life and death decision for somebody else. So I don't think these findings are surprising at all, but I think it's been important to show that they're real, they're really there, and they really do affect the way decision-making plays itself out in the hospital setting. And I think most importantly, these delays in decision-making impact a variety of things. And the case that I hope to make in the future is that in fact they impact what happens to the patient. I think we know that clinicians are distressed about these things, and that this may be a contributor to the moral distress of healthcare provider. We know that families are distressed when having to make these life and death decisions. But I think it probably costs more if decisions like this are delayed. But in the long run, the patient is really the one who's at the center of our care and concern. And I think it's probably the case that these things may actually affect patient care. So of course the study has limitations, the first of which is that it's a retrospective chart review. And so this entire analysis can only involve the patients who actually underwent the proposed intervention. We don't have any information, for example, on all the patients where a DNR discussion occurred, and in fact they decided to keep the patient at full code. And secondly, the chart review provides little information about the communication and decision-making process, and that's something that really takes other methods, which may include qualitative approaches or survey research. And finally, some of our patients who required surrogate decisions may have a major change in status that makes surrogate decision-making necessary only late in their hospital stay. So for example, an older adult may be admitted for an elective cholecystectomy, which they undergo on day 1. On day 2, they develop a post-op pneumonia. On day 3, they have respiratory failure and go to the ICU. And it's only at that point that the family's actually called in to consider end-of-life issues. And it's only at that point that surrogate decision-making actually becomes a relevant issue. So my goal to address some of these limitations is really kind of the next step, which is to design a prospective observational study of surrogate decision-making that's actually getting started right now. So this allows for the identification of patients who are at risk for a DNR order or other interventions, and not just the ones who had them. It'll provide much more in-depth data on the hospital course, including these in-hospital events that may change the course of a patient's care. And we're also doing qualitative interviews on communication and decision-making with the surrogates to really understand what their subjective experience is like and how this plays into the decision-making that occurs in the hospital. And this leads to my long-term goal, which is really to design interventions to improve the decision-making process, again, with the eventual goal of affecting the experience for the surrogate, but most importantly, to affect patient outcomes. So thank you very much.
Our next speaker is Rachelle Bernacki. Dr. Bernacki received her MD from Johns Hopkins, did her residency at the University of Washington, was a Robert Wood Johnson Clinical Scholar here at the University of Chicago, completed her Ethics Fellowship, remember that important theme of our panel, in 2005, and is currently Director of Quality Initiatives at the Dana-Farber Cancer Institute. Please welcome with me, Dr. Rachelle Bernacki, who is speaking about a new ethical issue. Is it ethical to pay a bonus to increase palliative care consults?
Hello, thank you, Mark, for inviting me. It's always wonderful to be back at University of Chicago. So I'm going to be talking about a project that I've been working on at Dana-Farber and at Brigham and Women's, and I'll be curious to hear your thoughts. So just an outline of what I'm going to discuss. I'll first talk a little bit about palliative care, then the specifics of my project, and then talk about the ethical concerns, both the anticipated and the actual concerns. So pay for performance is an emerging movement in payment to physicians and hospitals. In pay for performance, providers are rewarded for meeting pre-established goals or targets for delivery of healthcare services, and it's a fundamental change from fee-for-service payment. In a study from JAMA, over 50% of HMOs were reported using pay for performance. There's multiple examples. So percent of patients with MI discharged on beta blockers, patients immunized with influenza, or patients with diabetes that have a hemoglobin A1C less than 7. But the target or goal must be evidence-based. Since pay for performance is new, whether these initiatives actually improve care is debated, and that's outside the realm of my talk right now. But I really want to talk about palliative care and palliative care consultation. Palliative care consultation is a well-studied, evidence-based intervention that results in improved outcomes for hospitalized patients with advanced illness. So a former ethics fellow, Dr. Kasserit, did a study looking at palliative care intervention about whether it improved care. He found it was superior for decreased pain, care at the time of death, information and communication, care and setting concordant with a patient preference, well-being, emotional and spirit support, and access to services in the community. Another study, which was a randomized controlled trial of Kaiser patients in California, Oregon, and Colorado, the palliative care patients reported greater satisfaction with their care experience and providers' communication. They had fewer ICU admissions on readmission, and they had lower total health care costs following hospital discharge. In a study of 8 hospitals by Sean Morrison, he found that hospitals saved about $300 per patient, per palliative care patient, and that per admission they saved between $1,700 and $4,900. And they found that these significant reductions in pharmacy, laboratory, and intensive care costs means savings of greater than $1.3 million for a 300-bed community hospital and about $2.5 million per year for the average academic medical center. So if palliative care improves care and saves money, then who's doing it? Well, the University Health Consortium, which is here in Chicago, benchmarked 44 hospitals with mature palliative care programs in 2007 to determine the percentage of patients each palliative care program consulted in the hospital. They defined 2 patient populations of hospitalized patients. So they had an acute group, which was those patients with no previous admission in the last 12 months and died during the target admission, and then a chronic group, those patients with 2 previous admissions for any of 26 high mortality DRGs within 12 months of the target admissions. And both groups had to be over 18, and their length of stay had to be greater than 4 days. So when we got our benchmarking results at Brigham and Women's, we found that we only saw 15% of these 2 groups, and it was much lower than other hospitals. We found that our palliative care consultation service was underutilized outside of the oncology services, and there were opportunities to improve care for patients with cardiac, pulmonary, neurologic, and renal disease. And we had very low penetration into the ICUs. So Brigham and Women's, the Center for Clinical Excellence, partnered with Blue Cross Blue Shield of Massachusetts to develop a pay-for-performance initiative to increase palliative care consults at Brigham and Women's. The goal was to increase the consultation of hospitalized patients meeting these criteria from 15% to 25% by December 2009. So we're right in the middle of this initiative right now. And Brigham and Women's will receive withheld funds from Blue Cross Blue Shield if the palliative care service meets their goals. So the way this works is that Blue Cross Blue Shield negotiates a rate, and then they reserve part of that money and pay it back. And for my project, it's $1.4 million that will be paid to the hospital. So this was my worry, that palliative care would be being paid to kill off patients. And so this is my nightmare when I came to the Brigham. I thought that, oh my gosh, everyone's really going to perceive that we're being paid for this. And I would submit that this was not actually the ethical issue that I encountered. There certainly were a lot of ethical issues with this project, but that particular one was not really the case. And I'll illustrate that with an example. In the summer, I was asked to see a patient who was 92 years old with moderate to severe dementia. I came to see him in the surgical ICU, and this is one of the areas that we were not penetrating, and this was part of the initiative. And he was restrained, he had a Foley, he had telemetry leads, he had fallen and broken his neck, and he had a neck restraints, and he was moaning in bed, and his daughter was sitting there, and he was really delirious. So what we did was we took off all of the restraints. We took off his regular wrist restraints, his Foley catheters, telemetry leads, and I actually even convinced the surgeon to take off the neck brace. And I started him on some dilaudid and Haldol, and the next morning he was sitting up, and he said he was hungry. And so they had a swallow evaluation, and he didn't pass. And to make a long story short, I ended up feeding him Jell-O. And the attending surgeon came along, and he said, you know, this is really not what I was expecting from palliative care. I thought you were going to come, and you were going to start a morphine drip, and he was going to die, and you were going to talk to the family. And I said, well, certainly that happens. We certainly do that, but in this case, that wasn't the appropriate thing to do. And so we talked a lot about that slow hand feeding is the, you know, the choice care for patients with dementia, and he did very well with it, and he actually was discharged back to his assisted living. So this is my fiance's view of what I do. So Brigham and Women's palliative care, we won't unhook you till you're ready. He's kind of clever, so, okay. Okay, so a few more details about my project. So palliative care, so the hospital receives the funds. None go directly to the palliative care service. The project did receive IRB approval. We have a member of our ethics committee on our advisory board. And then we have our Center for Clinical Excellence providing support to assist in finding patients that qualify for the project. So one of the challenges of this project was that patients are few and far between. The patients that actually qualified, it was very specific, was about 2 to 3 patients a day. So we really needed help to find these patients. If a patient qualified, a request went to the attending physician and the primary care physician to see the patient. And the primary care physician, the attending physician, the patient or family could all refuse the consults. A licensed clinical social worker screened the patients for palliative care needs and then triage them to the appropriate person in the UHC palliative care team. We saw about 15 to 20% refusals. So the acute patients, it was usually, these patients were in the MICU, and the consults, the attendings felt the symptoms were well controlled, the family was well cared for, and so it seemed appropriate that we wouldn't see those patients. For the chronic patients, these patients were patients that had been admitted maybe twice for congestive heart failure exacerbation, and sometimes the attendings would feel that these patients weren't appropriate for palliative care to consult. Less than 5% of the time did the patient or family refuse, and when they did, it was mostly because they felt like they had too many people to talk to already. So I ask, is it ethical for any funds to be paid for performance initiatives? I would ask you whether our current fee-for-service system is ethical. Right now, any financial conflicts of interest are present in any payment system, and right now, fee-for-service really incentivizes doing more. So what instead I'd ask is, are palliative care consults any different? So they are. We're not simply measuring whether patients are on a particular medication, and the proximity of issues of life and death is much closer in palliative care. So ACP actually issued a position paper in December 2007, and that talked about potential ethical pitfalls. They talked about deselecting patients, difficult patients, gaming the system, misalignment of perceptions between patients and physicians. And what they meant by that is to measure and report quality for achieving patient-centered goals and increasing communication continuity and access. And finally, increase in unnecessary care and medical costs. So when I first read through these, I thought, well, palliative care, you know, we see the most difficult patients, we're trying to decrease costs, and we're all about communication. But then when I actually did the project, I found that we did have some of these problems. So one patient example is an RN would refer a patient that was actively dying but had had a previous admission. And initially we saw all the patients that were referred to us, but then we weren't meeting our goals. So only the patients that met the strictly defined UHC criteria would count for the pay for performance fund. and simply increasing our consult volume wasn't enough. So that we actually did see some patient deselection. So what we actually did was we still saw all the patients, it's just that we referred our patients from our University Health Consortium team to our regular palliative care consult team. And that was a little tricky because our palliative care consult team was already really busy, but they were able to work it in and triage and see the patients that needed to be seen. We were looking for patients that were dying in the hospital. I personally felt palliative care mismarketing. So the definition of palliative care as defined by CAPC, medical specialty focused on relief and pain, and is not dependent on prognosis, and that it can be given at the same time as treatment is meant to cure you. So at times, when I was rounding in the MICU, I really felt like I was going there and saying, bring out your dead, like the Monty Python, and that was really difficult for me. I think that it was another example of this misalignment of perceptions. So essentially it was finding the acute patients felt like we were mismarketing what palliative care did as a team. So what we did instead, we tried to say, for this initiative, we're really seeking patients that are at risk for dying in the hospital, but we will see patients at any point in any stage of their illness. And we tried to use that this was for the greater good, that we were getting into different areas of the hospital, going into the surgical ICUs, the neurology ICUs, and that we were making a difference there. So in summary, I think the palliative care pay-for-performance initiatives encountered similar ethical dilemmas as other pay-for-performance initiatives, including patient deselection and misalignment of perceptions, and that the ethical issues specific to palliative care and pay-for-performance were not as problematic as anticipated. Thank you.
Thank you. I am your next speaker, and I'd like to begin by deeply thanking Barry and Marianne. This is my 19th Fellows Conference out of the 21 that have been held. And it's a pleasure to be here, and I owe a very special thanks to Mark Ziegler, who came out last month to our own Ethics Center and helped us celebrate our 20-year anniversary and set some new goals and begin recruiting for a new endowed chair. And I just want to thank you very much for the successes we've had. In thinking about end-of-life care and the challenges that we all face, one of the challenges is that patients have wishes for end-of-life care, but those wishes are not always respected. That as people move from one setting of care to another, sometimes things happen that weren't wanted. And everybody can agree, and the discussions with appropriate surrogates can have taken place, and orders can be written, but our system of care is less than seamless. And so this may be the only talk of our panel that really focuses then on a systems and policy change that requires legislation and negotiating with the legislature to create a structured system that serves the entire state. In promoting full disclosure, with regard to the POLST program, our Center for Ethics in Healthcare does coordinate the entire state. We also staff the National POLST Task Force. And the more I do, the more I have the opportunity to fundraise to support this. There is nothing about the POLST program that makes a profit for our Center for Ethics in Healthcare. Each year I enjoy sharing how things are moving with the POLST program and showing the number of endorsed states has increased. Only a few weeks ago, Hawaii was endorsed. And an endorsed program means it's integrated throughout the entire state. It integrates emergency medicine, and that there will be seamless transitions from one setting. Developing can be all kinds of different things, including, for example, a group of nursing homes that might be using the POLST program, but not integration with EMS or a coordinated system. And then some regions of the country are very hopeful, and there are people working hard here in the Chicago area, but not yet moving forward with an integrated system. There's a lot of data, and had we more time, I would very much enjoy sharing a fellow and colleague who couldn't be here, Woody Moss, and I and other colleagues have been doing some studies on the effectiveness of POLST, looking at 2,000 nursing home residents in Oregon, West Virginia, and Wisconsin, and how POLST orders are used, what is followed, what treatments people receive, how many hospitalizations they receive in the final 60 days of life, and which sections of the POLST form work well and which are less effective. The main horsepower in a 1-minute summary is in Section B of the POLST form, which is on the screen. And Section B is not for someone who's in full arrest. Many of you know the data about full arrest for persons with advanced chronic illness and how little we impact the location of death in a resuscitation effort with a population that may have a 1% or perhaps up to 3% chance. Even witnessed arrests in cities with above average success rates like Portland, all comers is 10%, but unwitnessed arrests are far less than that. And while our studies have not found someone who received CPR who did not want it, that outcome does not have much impact on the overall outcome of care. Section B has a powerful impact. It's highly graded with whether or not you are hospitalized, whether or not you go to intensive care, depending on whether comfort measures only, limited interventions, or full treatment are marked. This is not yet published, it's in review, but there is a twofold difference in the rate of hospitalization between comfort measures only and full treatment, a profound difference in the amount of aggressiveness of treatment by Section B of the POLST form. For those of you who care, Section C on antibiotics makes absolutely no difference what is marked. If you mark you want them, you don't want them, you want them to decide at the time, the statistical rate is absolutely zero for any measurable difference in the final 60 days. You get it a third of the time. So that's just in case you're working on POLST in your state, like Illinois, you might not want to use the antibiotic section, doesn't feel very effective, but you'll learn that more later. Now, there is a problem. The form works well if found. It does determine rates of hospitalization, death in the hospital. Our own palliative care team has done a study of people discharged after a palliative care consult, all of whom receive POLST forms on discharge. For the 2/3 who leave the hospital alive and followed them until death. And what we found was that only 5% of that population ultimately died in an acute care hospital anywhere in the state of Oregon. So we know that the form has incredible power for helping guide care, particularly with regard to rehospitalization. But sometimes the form cannot be found. These are forms out in community. They're on refrigerators in private homes for people in home hospice. And a statewide study of emergency medical personnel found that 1/4 of the time, in a time of crisis, the form was not immediately available. In doing focus groups with people in retirement communities living in senior living, the majority of whom have a POLST form, most of whom are marking limited interventions, they want the easy things fixed and do not resuscitate, do not want to look at it every day, and half of them said things like, it doesn't match my decor, it's not the refrigerator repairman's business, and I don't want to look at this every time I get my milk. So it became very clear why EMTs were not finding POLST forms in community settings. They find them much more often in the front of the nursing home chart. But in more community settings where POLST has widely penetrated now with people with more advanced frailty, they weren't being found. So to take this to the next level, we needed a backup system. And designing a backup system for immediate access when you're already out in the field and found down was the challenge we took on over this last year. How can we get the information to this crew right here out in the garden where this woman collapsed from heat exhaustion? And how can we do it and respect HIPAA, and how can we do it across all different kinds of radios and other things in a state that has a lot of rural population as well, and make this statewide and integrated and design a way that not only that, but we can get where they're going to deliver the patient and have the post form waiting in that emergency room. So that was the goal of the innovation that we have set off on over this period of time. We have two timelines: how to develop this, build it, develop research around it, and fund all of that through private philanthropy. We have felt strongly that the POST program needed to be retained and protected through private philanthropy because of the possible appearance that disseminating POST more widely could save healthcare costs. We have held this as a goal since we developed the program in 1990, and the reinforcement for the value of protecting it from the appearance of a weapon of cost savings became much more clear in the last few months with discussions of death panels and others. And during the legislative process, we actually formally invited Blue Cross not to testify in our behalf. And I'll explain more why. That also was just prior to all the death panels and things. But the potential appearance that you are offering people to save money, even though we might provide dialysis in the last week of life with multi-organ system failure and make a profit, that sense when you have difficult economic times and a state budget that is billions of dollars in the hole, that you might plug that hole by depriving people of life-sustaining treatment is a very dark shadow that is extremely dangerous on a public forum. So we concurrently began developing, with funds from the Greenwell Foundation in New York, and I'm sorry Bill Stubing isn't with us today, the database that would be needed. Found down means you don't know who that person is, and to match them with a registry of identifiers to connect them with the right post form means developing software programs for the different types of information in every context EMTs might be able to find in the field. They know the address they're at, but that might not be the address the patient is at the time they collapse. They may know primary care provider, they may know date of birth, and so on. So it gives you a sense of the kind of program that we needed to develop, and we could never be wrong. We could never give you the information about a different patient. So we loaded hundreds of mock charts. We had EMTs make phone calls into a communication center. We tried to design ways that errors would be created. We hired people to come in and try to break the database in various ways. They taught us how to make it much faster, which we appreciated. We then, also with private philanthropy, launched a pilot test in one county that we had a lot of control over. My conspirator in building all of this is Dr. Terry Schmidt, and she's the medical director for EMS for Clackamas County, which has 400,000 people, an ideal location, certainly a convenient sample for why we started with Clackamas County. We did that at the end of May and continued our testing on systems. Then looking at the legislative pathway, for 2 years we've been working with the legislature. One was a bill to create a coalition to make recommendations for healthcare change. So 2 years ago in that bill, the Health Fund Board was to design a post registry, and there's just one line. That board did come together, did make a recommendation to create a statewide registry. It became part of 7 bills that's over 600 pages long. We are 4 pages about the electronic post registry. And despite this being a very adverse economic climate in the legislature, we did pass this legislative session the creation of a statewide post registry, which does provide funding only for the operations of the registry, not the post program, which remains private. And under the auspices of the Ethics Center, all of the education remains private statewide. We do not want any incentives that encourage the use of post forms or use it sooner than is appropriate or mandate the completion of post forms. So we've been extremely cautious about that. The legislature was signed the bill into law at the end of June. The contract has recently been completed, and in the meantime, with private philanthropy, we've been loading and continuing to further test. We have 4,000 forms submitted. We go live next month statewide, meaning taking calls from EMTs. We expect to load 50,000 post forms a year, and we archive immediately if we get a new post form, so we'll be able to see how people change over time. We will have a database that tells us if we were in hospice, how our forms typically competed. If you're in a nursing home, because we're categorizing by setting from which we receive these. So we will have an enormous database. We also learned something we had not anticipated. 10% of the times the forms are not completed appropriately, we can't enter them. They are missing things like a date, which is vital. If you're knowing which form is the most current, we return all of them. Dear doctor, your form is incomplete for the following reason. Please complete it and return it. But we had not expected to have this level of quality impact on the program across the state, a much greater degree than we had expected. There are two other remarkable things that having the statute do. Oregon has not done the PULSE program by statute until this point. Everything is in regulations. Other states like New York and California have laws about PULSE programs. By having a mandate to submit, if you sign a PULSE form as the physician, you must submit it to the registry just as you would an immunization record unless the patient wishes to opt out. By requiring that, it automatically satisfies HIPAA, because a mandate to submit means you don't need an authorization to submit. Authorizations to submit, we learned in the pilot phase, were incredibly burdensome and greatly reduced use of the registry. Unless we get about 90% of PULSE forms in the registry, we're really going to be compromised when EMTs call and look for a document in serving our community. So this will incredibly increase the use and effectiveness of the registry. It also funds registry operation. The economic stimulus for student workers in Portland has been increased by the PULSE registry. We are hiring them by the dozen to load PULSE forms, and I didn't wish to pay for that long term. And so the actual operation of the registry is paid for by the state, and it's $740,000 for the biennium is the cost to the state. Remembering they are not doing anything with education, which actually costs more than that over the 2-year period of time. We want to emphasize this and can't overemphasize this. The PULSE program is voluntary. Completing a PULSE is voluntary. How you fill it out is voluntary. You can change your mind and you can opt out of the registry. I took a lesson from Peter Ubel here. Note, you don't opt in. You can only opt out. And about 1 person in 500 is opting out. But clearly we would like them to opt in, but we understand there are a few people very worried about Big Brother and registries, and we didn't want to battle them in the legislature, and we're happy to allow them to opt out. We have to say anticipated go live. We're still in the rulemaking process, but we do expect that the whole go live will be December 1st. And we have, the Attorney General's office has given us permission to use the word anticipated. So it is with deep gratitude that I thank Bill Stubing and the Greenwall Foundation, who paid for the very first grant in the early 1990s to build the PULSE program in the first place, several of our research studies along the way, and specifically the database that built the registry. And I'll welcome your questions at the end with my other colleagues. Thank you very much. And I will now turn my moderator hat back on and would welcome the introduction. My assistant will again help us in the interim to introduce our next panel member, Farr, who got his MD at the University of North Carolina School of Medicine. He did his residency here at the University of Chicago in internal medicine. He is the founding director of the program on medicine and religion at the University of Chicago. He is speaking to us on Do the Goals of Sedation Terminate at Palliation? I look forward to his remarks.
Thank you. Well, after giving Mark this title in the spring, I procrastinated, as I sometimes do, on how to organize my comments. And a few weeks ago, Tim Quill and Bernie Lowe and Dan Brock, who's present, and Alan Mizell published an essay titled Last Resort Options for Palliative Sedation in the Annals of Internal Medicine. So Dan, you can hold my feet to the fire if I in any way distort the arguments that were put forward in that essay, but I'm going to use that essay to sort of organize my comments and start with a lot of words up there, but I'm going to read this. The case that with which they started their essay. A 50-year-old man had battled lung cancer for several years before transitioning to hospice. He hoped to die comfortably at home with his family, but he feared severe suffering on the basis of experience with other deaths in his family. His palliative care consultant assured him that if his suffering became severe and unacceptable, he could receive total sedation as a last resort. He enrolled in a home hospice program in a small town in an adjacent state, and the local hospice medical director became his treating physician. The patient assumed this option was still open to him if needed. For 2 months, he had good quality of life and many meaningful experiences with his family, but when his dying later became both physically and psychologically unacceptable, intractable nausea, vomiting, weakness, and fear, despite skillful treatment by his hospice team, he asked for total sedation. The hospice team felt uncomfortable about such sedation and refused to provide it. No alternatives other than the status quo were presented. The hospice and its medical director were very uncomfortable with the patient's request, and their organization had no formal policies or guidelines for palliative sedation of any kind. No other hospices were in the city, and the patient was too ill to move to the acute palliative care unit at the site where the original consultant practiced. After extensive discussions with the patient's original palliative care consultant, she arranged for sedating medicines to be delivered from a local pharmacy to the patient and family at home. The patient was disenrolled from the hospice, and the staff was forbidden to see him. The sedating medication was increased in a stepwise manner over hours such that the patient was resting comfortably, which ultimately resulted in his being rendered unconscious. He died peacefully 4 days later. The patient and family were deeply grateful to their original palliative care consultant, but felt abandoned by the local hospice program at their time of greatest need. And the hospice staff caring for the patient felt demoralized and guilty. Now, this case introduces a moral argument that some, and I think these authors perhaps most prominently, continue to advance. Namely, that in such cases it is not enough for physicians to use sedatives merely with the intent of relieving distressing symptoms and in doses proportionate to those symptoms, accepting unconsciousness as a foreseen but unintended potential side effect. But rather, physicians may, and sometimes should, sedate with the goal of making the patient unconscious. And as a practicing hospice and palliative care physician myself, this subject is not merely academic. And here I will counter the arguments of Quill and colleagues to suggest that the goals of sedation do rightly terminate at palliation. The authors appropriately distinguish two acts of sedation. There's what they call proportionate palliative sedation, and I'll use the language that they use. No need to quibble with that at this setting. What they call proportionate palliative sedation has the intended effect of relieving refractory and distressing symptoms. An unintended effect of some potential unintended effect of decreasing the level of consciousness of the patient, which may also hasten the patient's death. And the dosing with proportionate palliative sedation is proportionate to the severity of the symptoms. In other words, we don't treat an itchy nose with sedative-induced coma because no other medications will treat that itch. It's proportionate to the amount needed to control those symptoms. We don't use 10 milligrams of Ativan when 2 milligrams will do. And it's proportionate to the overall condition of the patient. So when a patient is dying from an incurable disease, it is reasonable to worry less about the side effects of sedation than if the patient were otherwise healthy. Palliative sedation what they call palliative sedation to unconsciousness, it seems to me probably should be more accurately just called sedation to unconsciousness, but I'll set that aside for the moment. Its intended effect is unconsciousness as a means of the overall goal, as it's put, of relieving the patient's suffering. In their words, in the essay, they write that in palliative sedation to unconsciousness is the intended goal of the sedation rather than a side effect. Its unintended effect is hastened death. And I put the question mark there, but, not to challenge the good faith of the authors, but in this essay, the authors write that although the purpose of palliative sedation to unconsciousness is to relieve otherwise intractable suffering, the patient is always rendered unconscious as an endpoint and therefore cannot take food and fluids by mouth, which may have the unintended effect of hastening a patient's death. But they cite as a reference for that an earlier paper by Quill and Dresser and Brock, in which they criticize the rule of double effect, among other things, and write, although the overall goal of terminal sedation is to relieve otherwise uncontrollable suffering, life-prolonging therapies are withdrawn with the intent of hastening death. So I think we can still, for the purposes of my arguments, though, take it at face value that the intent is not to hasten death, it's just to make the person unconscious. And the dosing is titrated to induce deep sedation. Now, even those who support palliative sedation to unconsciousness have referred to it, as these authors do, as a last resort measure, a measure to be used when other resorts, including proportionate palliative sedation, are not enough. So the question I think we start with is, what is it that palliative sedation to unconsciousness treats that is not treated by proportionate palliative sedation? Let's go back to the vignette. I'm going to highlight that this line, that when his dying later became both physically and psychologically unacceptable, intractable nausea, vomiting, weakness, and fear, despite skillful treatment by his hospice team, he asked for total sedation. Now, as a clinician, I would ask myself, but what is it here that the proportionate palliative sedation cannot address for this patient? And Quill and colleagues here, write that palliative sedation unconsciousness is usually initiated when the immediately dying patient finds severe physical symptoms intolerable, despite the state-of-the-art palliative care, and continuing consciousness under the circumstances is unacceptable. The framework of proportionate palliative sedation addresses nausea, addresses vomiting. It even addresses neurocognitive symptoms such as severe anxiety. So again, the question is, what is left? And I think if we go back to the vignette, it starts to become more clear. The authors mentioned that the patient feared severe suffering on the basis of a prior experience with deaths in the family, and was concerned that if the suffering became severe and unacceptable, I think that's a key term, and I'll come back to that, the patient can receive this total sedation. In an earlier paper, Quill wrote the following: some patients who have witnessed harsh death want reassurance that they can escape if their suffering, they can escape if their suffering becomes intolerable. Elsewhere, summarizing the experience of physician-assisted suicide or physician-assisted death in Oregon, Quill notes that patients who have received prescriptions for life-ending medications in Oregon, quote, tended to be at least as motivated by concern about losing autonomy, dignity, and control over their bodily functions as by any suffering from immediate intractable physical symptoms. So it seems to me that what proportionate palliative sedation, which is generally universally endorsed in the palliative care community, may not provide, is control over one's consciousness and escape from that consciousness that some patients find, the absence of which some patients find to be intolerable or unacceptable. And with that in mind, I think we can revise and simplify the vignette to clear away some red herrings and focus on the question at hand. So we have a 50-year-old man who's battled lung cancer for several years before transitioning to hospice. After 2 months, he develops intractable nausea, vomiting, and weakness. As the hospice team worked to relieve these symptoms, the patient asked for total sedation, noting he was afraid of further suffering and found consciousness itself intolerable in his condition. The hospice team explained that they were committed to addressing his suffering and would redouble their efforts to relieve his nausea, vomiting, and anxiety, escalating the doses of medications as much as needed to relieve those symptoms, while being present to him as he died. They explained that the higher doses of medications, coupled with the patient's weakened condition, might make him unconscious, and if so, that would be acceptable, yet they would not make him unconscious as a goal in itself. Now, is it understandable that a patient would want control, would want the option of escaping from their existential condition in such situations. It seems to me clear that, of course, that's understandable. The question is whether doctors should facilitate that escape. And I'm going to give at least 3 reasons the profession should steadfastly resist moving in this direction. First, consciousness is an expression of health, not a condition to be palliated. There are, of course, times in which we make a person temporarily unconscious in order to do something, like operate on them, that is necessary to preserve or restore their health. In all such cases, the goal is restorative, to wake the patient up again to an improved condition of health, which includes consciousness. Those who support palliative sedation to unconsciousness counter that the end goal, the overall goal as it's put, is in fact to relieve the patient's suffering, which can only be done by making the patient unconscious. Here we have an action with 2 foreseen outcomes, one good, relief of existential suffering, one bad, the loss of the ground of existential experience or consciousness. And, wait, 15 minutes? It's been 14 minutes? Okay. Sounds like a situation in which to invoke the rule of double effect. The rule of double effect has been an indispensable guide for the practice of medicine for a long time because almost everything we do in medicine has both good and bad effects. Quill and Brock have elsewhere rejected the use of this rule in end-of-life decision-making, but in this essay at least, they tacitly appeal to it by repeatedly distinguishing intended and unintended effects. Now, put simply, I'm not going to spend a lot of time with this, the rule of double effect holds that when an action has 2 foreseen effects, one good and one bad, the action is licit if 4 conditions apply. The action is not in itself immoral, one intends the good effect only, the bad effect is not the means of the good, and there's a proportionate reason for the action. I won't go into this further except to say that palliative sedation unconsciousness fails at least the 2nd and 3rd conditions. And if you want to think more about this, you can read the literature where Dan Sulmazy and colleagues and Tim Quill and Dan Brock and colleagues have been jousting about this over the past several years. So the first reason that physicians should not use palliative sedation unconsciousness is that consciousness itself is not a condition to be relieved. The second and related reason is that removing consciousness is not a fitting way to address existential suffering. Existential suffering is real. In the face of bodily suffering and death, 2 inescapable conditions of being the finite, self-conscious, embodied creatures we are, in face of that, many people experience fear, sadness, regret, and other painful emotions. And in my own experience, and I would imagine in others, patients with more unresolved existential concerns also tend to experience more refractory pain, anxiety, and other symptoms. Existential suffering cannot and should not be treated in anything like the instrumental way we treat visceral pain and breathlessness, but we can and should treat clinical depression, anxiety, and other neurocognitive symptoms. Moreover, there are ways of responding to existential suffering, including clergy, chaplains, and other spiritual care professionals helping patients think through and work through their difficulties and their fears and questions. Insofar as the patient allows, we can encourage friends, family, and others who love the patient to spend time with them, listening, talking, touching, and being present to them in their suffering. This practice of presence also goes to the heart of medicine, and I'll close with this. The idea of an attending physician comes from the notion of attending to or being present to the one who is ill and suffers, and I think Rachelle gave us a really powerful picture with that story of feeding the patient Jell-O, right, while she used Dilaudid and Haldol to treat the patient's symptoms, understanding that it might make him unconscious, and was even surprised in the end that he woke up. But this brings up the last, and I think the deeper reason that the profession of medicine should doggedly resist all efforts to normalize and all the temptation to engage in the practices of sedation to unconsciousness. And that is that the practices are inconsistent with the nature of the practice of medicine. The normalization of palliative sedation to unconsciousness is part of what I think are pernicious shifts in our self-understanding as physicians. We see ourselves less as professionals who attend to patients so as to preserve and restore their health, and more as providers of healthcare services, as the language is used, which are made available to relieve patients of any condition they find unacceptable or intolerable. In the end-of-life setting, we shift our language from intractable or refractory symptoms to unacceptable or intolerable conditions or states. We're shifting on all fronts, it seems to me, from a principled and focused commitment to a partial good, namely health, toward a generalized and unbounded commitment to help patients relieve themselves of those conditions they do not want. And one consequence of these shifts is the rationalization of death in practices like sedation and unconsciousness. In our anxiety to be rid of suffering, we eliminate the sufferer. In this case, our solution to the existential suffering of the patient is to end his existential experience altogether. And that is to intentionally and irreversibly remove the capacity for self-consciousness that is so central to human identity and experience. So for all these reasons, I'll close by agreeing with the last sentence of the essay by Quill and colleagues, which is that the obligation of clinicians who care for seriously ill patients at the end of life to address intractable suffering requires that they become informed about available options and that they be as responsive as possible without violating fundamental ethical principles, one of which I would suggest is to not intentionally and terminally sedate patients to unconsciousness. Thank you.
Our last panel member is Paul Helft. He did his MD and his internal medicine residency here at the University of Chicago, and that was followed by fellowships in hematology, oncology, and clinical medical ethics in 2001 here at the University of Chicago. He is currently director of the Charles Warren Fairbanks Center for Clinical Medical Ethics at Indiana University.
Well, I would like to thank Mark and the meeting organizers for allowing me to present this study from an ongoing research project. I'd also like to thank the MacLean family for their ongoing support of our work. See if I can get this right. 15 minutes, right, Susan? Yes, sir. Okay, here we go. So I just wanted to acknowledge my collaborators, Maggie Urich, one of our oncology nurses who did the heavy lifting in this project, Colin Terry, our statistician, Amy Chamness, who is our program coordinator, the foundations who have supported our general work, and then my own research funding line. And I got interested in this project. This project really stems out of my general interest in end-of-life care, in particular deficits in end-of-life care for people with cancer, which has tended to focus on doctor-patient relationships, leaving out the other clinician-patient relationships that may actually have an impact on patients' care at their end of their lives. So I'm going to use a few terms in this, and I just want to define them very briefly. I'm going to use the term prognosis-related communication as a more general term related, because the term prognostication has very specific meanings, mostly tied to doctor-patient communication. And this is a more general term by which I mean things like when clinicians or patients raise the possibility of dying from cancer, introduce the notion of hospice or palliative care, and these other things. I'm going to use the term ethical conflict in a very general way to mean internal or external moral tensions created by communication with patients and families about prognosis-related issues. And then finally, the term advanced cancer patient, by which I mean that group of patients with incurable cancer, terminal cancer, or life-ending cancer diagnoses. Surgeons in the audience, who is this? Yes. Gretchen. Martin. So this is Robert Zollinger, made famous. He was a surgeon in the 1940s, and he coined the term for oncologists, medical oncologists, ambulatory morticians, which I have taken to heart in many ways. There is a great deal of evidence, in fact, that there is inappropriately aggressive care at the end of life for cancer patients. There is also appropriately aggressive care at the end of life for some patients, but there's clearly inappropriate care for another group. And these are just some of the statistics which I put forward to your attention. A third of cancer patients receive chemotherapy in the last 6 months of life, a quarter in the last 3 months, and 10% in the last month of life. If you look at Medicare-only patients with metastatic cancer, they started a new chemotherapy regimen within 2 weeks before death, 1 out of 5 patients. The median length of stay in hospice over the course of the last 10 years has actually declined, interestingly, not increased, to 21 days in 2006, a third of patients enrolling in the last week of their life and 10% on the last day of their life. In the largest study done to date of cancer patients receiving palliative chemotherapy, prognosis, according to the patients, was discussed by medical oncologists with only 39% of patients. That is, patients could recall a conversation 40% of the time. And finally, in an important longitudinal study of hospitalized patients for whom death was believed imminent, families reported that the attending physician never discussed the possibility of death about 2/3 of the time, and no one on the medical team discussed the possibility of death with cancer in 40% of cases. So clear evidence that there are deficits. My personal belief, by the way, is that oncologists are not all bad, that some of us are, really good at doing this, some of us are moderately good, and some of us are not good at it. There are probably three groups, in fact. There's also evidence, as you know, that increased prognostic understanding leads to decreased uptake of these aggressive treatments. And these are just two examples from the vast literature on this particular problem. For example, in the SPORT trial, patients who thought they were only going to live 6 months were 2.5 times as likely to choose, were going to live for at least 6 months, 2.5 times as likely to choose aggressive anti-cancer therapy instead of palliative care. And then in Murphy's study, the attitudes toward cardiopulmonary resuscitation of ambulatory elderly patients, the authors found that 95% of patients did not want to undergo CPR once a clinician explained the probability of survival after the procedure. So again, just several examples. So what is nurses' role, oncology nurses' role in prognosis-related communication? It turns out a number of things are probably the case. One, nurses are well situated to facilitate communication about hospice and palliative care in terminal cancer patients, both in inpatient and outpatient settings. This derives from the fact that they spend a significant amount of time with patients in those settings, whether it's getting chemotherapy in the infusion area for multiple hours or whether it's seeing patients over the course of a 12-hour shift in the hospital. The extent, however, to which nurses engage in this communication about prognosis-related information is very unclear. Research suggests that nurses may have more opportunity for communication with patients than they actually are able to accomplish, and they clearly act as intermediaries between patients and physicians. However, almost no research has examined the role that oncology nurses may play in this problem. So therefore, I would argue that nurses have several things that are important to this problem. One is that they have knowledge, at least the experienced ones do. Two is that they may have opportunity. And third is that they clearly have a strong professional commitment. And our preliminary data around this problem suggested, however, that there were barriers to them engaging in communication about prognosis-related information, and that it was useful to frame these as ethical problems. That is, they were concerned that this was within the scope of nursing practice or not. And they were very concerned that they wouldn't say something that had contradicted a story that the patient understood from their physician. And finally, that all of them, almost to a person, argue for the advocacy role for patients, and that sometimes comes into conflict with this kind of information. And so the research questions from this study: what are oncology nurses' perceptions and experiences of prognosis-related communication with these patients, and what are their perceptions of this kind of communication among the oncologists with whom they work? So I'll go through this very quickly. We did a random sample of Oncology Nursing Society members. That's the largest society in the world of oncology nurses, more than 30,000 members. We sampled more than 1,300. We developed a tool internally and did 3 mailings in 3 months. We got 394 completed surveys for a response rate of about 30%. The population really maps onto the population of oncology nurses in general. Median age is 50 years. I want you to note that. That has to do with the aging population of nurses in this country. And I just want to share with you a few of the results which we found interesting. These are the results surrounding nurses' experiences with prognosis-related communication. Half of them felt that they always or often cared for advanced cancer patients who did not appear to understand their prognosis. 60% always or often encountered questions suggesting that they wanted more information. 3/4 agreed that answering questions regarding prognosis-related information was within the scope of nursing practice, and a good majority disagreed that nurses should provide numerical estimates of life expectancy. Half of them felt comfortable telling a patient he or she will likely die from the cancer, however, and 40% disagreed that they were well equipped to engage in such prognosis-related communication. 43% agreed that uncertainty regarding their role was a major barrier to helping patients understand. Half of them felt ethically conflicted, and the majority of them agreed that lack of time, fear of taking away hope, and physician discomfort were the major barriers to prognosis-related communication, and nearly all of them felt they should have more information. Inpatient nurses, we found, were more likely to encounter such questions, to be present when the doctor discussed the information, to ask about advanced directives, and to agree that when patients appeared not to understand their prognosis, it was because doctors had not discussed it fully. And about a half of the nurses we surveyed, sometimes, often, or always avoided talking with patients because they were uncomfortable giving bad news. I'll just skip over the view of nurses in the interest of time. Oncology, that we asked them a separate set of questions about how they perceived the doctors with whom they worked closely did this, and we found significant deficits, as you can imagine, reported by the nurses who answered our survey about this sort of thing. For example, a quarter of them disagreed that the doctors they worked with were skilled at prognosis-related communication. And in exchange for that time, I'll just share with you a couple. We left space for comments, and we actually got 170 written comments, which we did not expect to do, and we're in the process of sifting through, but I just want to share a couple of them with you. I think they're very telling. At the institution, this is one nurse who wrote back, "At the institution where I work, it's the practice to wait for the patient's attending physicians to talk about prognosis-related information. All other physicians and nurses are reluctant to talk about it until a discussion has taken place between attendings and patients and their families. This sometimes causes a delay, during which time patients are left anxiously waiting for their attending to give them information." You wonder what role this nurse could have during that time. I'll share this last one with you. I've had experiences where a patient's condition is clearly deteriorating, but a family member will say, "Dr. X says we can start a new treatment as soon as the patient gets over this breathing problem, diarrhea, swelling issue, whatever. I know the patient has only a short life expectancy, and I think, darn it, the doctor owes them that understanding." On a number of occasions, I've taken that conversation forward and said, "Let me tell you some things I believe you need to know. I'm always torn between what I feel is the nurse's role, and I don't want to irritate the physicians, but if I don't open up the conversation with the family and patient, the patient will continue on to a death without the benefit of having made any or enough of a plan for it." So we concluded from this study that oncology nurses engage in prognosis-related communication. However, their views regarding their role vary, and practices seem to vary, but they have clear feelings of ethical conflict which arise during and in this domain. Oncology nurses identify these deficits that are again, well known among the oncologists with whom they work. And these include things like not sharing the content of their own communication with their patients and other aspects of collaboration around providing patients with prognosis-related information. Thank you.
With that as our ground rules, are there questions for the panel? Yes. Please introduce yourself and your question.
Family. We know the doctors do outpatient visits, but in our experience as a family, it's like a random luck as to when you're going to know that the attending the hospitalist is going to show up at the bedside of the patient. Some of the family is left trying to be around this mysterious time the doctor is going to be there. They miss them, they're gone forever. I mean, have you thought at Curlin about improving customer service basically hospital working by having a scheduled inpatient appointment, which most physicians might possess because they have the freedom to walk around and do things, as a way to try to get the family and the physician talking earlier about the patient's situation, or is that too radical an idea?
Alexia?
And I think, just to answer that question, I point to the research of Randy Curtis and White and others in Seattle, who actually did a randomized control trial of having a family meeting within, I believe it was 48 hours for patients who were thought likely to die within the ICU. And not only did it change the course of care for the patient, it actually improved outcomes of distress for the family member. So I think there's evidence that early scheduled conversations can work.
I would just add that, while it is true that there are individual patients where locating enough family members or the right family members is difficult, in general, I would say that families are extremely grateful for the opportunity to actually sit down for a half hour, 45 minutes, or an hour and do this. So in general, I have found, for the most part, that families will sort of bend over backwards if they get an hour of the physician or the care team's time. There are several groups around the country doing these sort of intervention sorts of studies where a mandatory family meeting must take place in certain groups of patients, within 5 days of admission.
Rachel, did you wish to comment?
Our system is that our social worker coordinates a family meeting. It's about once a week for hospitalized patients, so.
Mary?
I really appreciate your paper, but maybe I need some clarification. Terminal sedation is only known to be terminal. The patient actually dies. You mentioned, I think quite importantly, that unconsciousness is an inappropriate goal. And I guess I thought to myself, sometimes in my own life, I've been dealing with some, what I might say, existential angst or pain, suffering, whatever you might call it. I really want to go to sleep. And I try to go to sleep because I know that going to sleep is going to give me relief from that suffering. So is your argument contingent on the idea that this is intended to be permanent unconsciousness? Whether it turns out to be that or not, but intended to be. Whereas I know that eventually I'm going to wake up from my sleep. Or is it wrong for me to really try to go to sleep?
No, it's definitely not wrong, I think, to try to go to sleep or to get relief from painful existential suffering. Sleep is also an expression of health. As I understand it, the argument for palliative sedation unconscious, I think quite clearly, is that it is terminal, meaning that the intention is to keep the person unconscious until they die. And so that, I think, makes it, that's part of what makes it unethical.
Father O'Rourke?
I'm wondering about this application of double effect. And it seems to me that you have to be certain, or at least morally certain, that the symptoms that you're dealing with cannot be alleviated in any other way. But it seems to me that if they can be alleviated in another way, that you have to use those means rather than inducing unconsciousness. Would like to comment on that.
I guess presuming that there's another way that does not have the same, that has a better balance of good and bad effects, then yes, you would have, to the extent that were true, you would have an obligation to use the other way. But perhaps there'd be other ways that would be worse than, in the case of someone with severe suffering, than using sedatives to relieve that suffering with the unintended but foreseen side effect of sedation.
My comment is that after listening to the part about palliative or total sedation, going to a lack of consciousness with death as an endpoint, with these few minor differences in what I do is it is euthanasia. I mean, if the sedation has no other endpoint but death, if that's the point, then the only argument is really how long it takes. And I would argue that there's just no difference in terminal sedation and euthanasia in my practice. Euthanasia is done daily, but we don't sugarcoat it. It's a veterinary practice, and I'm holding out on purpose. I'm a veterinarian, so there's a difference. But I practice euthanasia every day. My argument is when I give an injection to euthanize an animal, the difference in what I'm doing in terminal sedation is how long it takes. That is it. By the time my clients leave, 20 minutes later, we're finished. What you're doing in terminal sedation may take a week. Now, the only subtle difference there, it's an important difference, is the dose effect of what I do deliberately causes that heart to stop. What you're waiting for a little bit is the metabolism, the disease process, the other things to shut that down. But I would at least make an argument in theory, looking at it a little bit higher up, there isn't a lot of difference.
You don't wish to respond, okay. September.
Just speak loudly.
Speak loudly.
So I I'm trying to sort of synthesize a number of things that have happened here. One of the things that we've done at the large long-term care hospital in San Francisco where I work with Tolle is we've built it into a drop-down menu for the lifetime clinical record, which touches to the city and county acute care hospitals and the UCSF. We have added to Pulse all of the elements of Pulse, a specific question about whether or not people would prefer to be conscious and awake near the end of their life. Because I don't really know how people answered that question. And we thought it would be a nice way to figure it out. I had a question for Rachel specifically about the decision to increase the number of palliative care consults from 15 to 25%. How was that number reached?
It was meant to be a stretch goal, so it wasn't quite doubling it, but it was negotiated between Brigham and Women's Hospital and Blue Cross Blue Shield. Based on what? Based on, right, so on the hospitals that they had norms from the hospitals that they looked at, the 44 hospitals, and the mean actually of the 44 hospitals of that in the mature palliative care programs was closer to 40% of those patients were being seen. So it wasn't even quite getting to the mean. So the patients so for the chronic patients, those patients they had 2 admissions with one of 26 of the highest mortality DRGs, meaning that they looked at all of the DRGs that people leave the hospital with, and then have a risk of dying. So, but when I saw those patients, those are patients that come in, say, with a COPD or exacerbation twice in a year, CHF exacerbation twice in a year, and they actually may have a very high mortality, but what we saw was that was more of an early palliative care intervention, so we got people to start thinking about their healthcare proxy, start thinking about their advanced directives, but we weren't discharging those patients to hospice by and large. They were seen by the palliative care social worker. They often didn't have as many physical symptoms, and that it wasn't always necessary to have a full palliative care consult. But they were seen by the palliative care social worker.
And a final question, Ron Miller.
One for Torke. Is there an ethical way for you in your future studies to ascertain whether or not there's synchrony between what the patient would have lived and what the surrogate states? And for Dr. Tolle, might it be helpful in getting understanding of the disability community to reverse the order in B, having full treatment first and comfort measures only last, rather than the sequence that is so common on both boards generally?
Excellent. Alex?
I think the area of concordance between patient wishes and surrogate wishes is something that a number of other investigators have tried to look at. In fact, a meta-analysis has shown that overall, if you take patients at time 1 and ask them to put them in one room and ask them to describe a scenario, ask them to state their wishes and put a surrogate in another, the overall agreement is about 68%. So it's fairly poor. I mean, I think that's kind of the overall data on that. The challenge with our study is that we're doing it in the time when the patient lost capacity, and except in rare circumstances, they're never going to wake up and tell you. And so I think the focus of my research is a little bit more on the time when surrogate decision-making actually occurs, and unfortunately it precludes gathering some of that data. But I think we do have a good evidence base that predictions are, moderately bad.
Your question about the order on POLST has been much debated nationally, and there are states like North Carolina who do have a different order which requests the treatment first. In working with the disabilities community throughout our state, and we've met extensively with a number of major disabilities leaders and spent a year divining a document, because what we learned in the disabilities community, whatever we put as far as the order on the form, was of less interest. And what was of concern was was this seen as a life not worth living, and finding the spot to check wherever you put it was of significant concern as a possibility. Also, a number of people had concerns that members of the disabilities community who were actually approaching end of life were not receiving quality end of life care because the decline from a much lower level of function was not precipitous enough to lead people to make the transitions in care that occur when people are starting at a much higher level of function and the decline is noted. So we had problems on both sides. We wrote an extensive document that you can read about this with the disabilities community on the at pulse.org, click on Oregon, and then there's a document that really deals with both sides of this equation, which I think goes much beyond the did you switch the order and really deals with the essence of are we inappropriately marking post forms for persons with disabilities in one way or another, an area of tremendous interest and concern in trying to be sure that we actually appropriately mark wishes and values in accord with the patients and their appropriate surrogate so that they reflect the appropriate care at every stage of the illness, including inadequacies when they were actually approaching end of life, had been a DD patient their whole life. I would like to thank the panel tremendously for their participation.